I want to describe something that is happening to approximately 1 billion people tonight while they sleep. Their airway repeatedly collapses. The muscles of the throat relax to the point where the upper airway becomes obstructed. Breathing stops. The blood oxygen level begins to fall. After several seconds, sometimes 10, sometimes 30, sometimes 60, the brain detects the oxygen drop and fires an emergency arousal response. The person partially wakes, the airway reopens, they take a gasp of air, and they fall back to sleep. Most of the time, they have no memory of this. And then it happens again and again. In severe cases of obstructive sleep apnea, this cycle occurs more than 30 times per hour. Some people experience it 60, 80, even 100 times per hour throughout the entire night. Now, I want you to think about what that means for the body. Every apnea event is a hypoxic stress, a period of oxygen deprivation that the brain and cardiovascular system must respond to. Every arousal fires the sympathetic nervous system: adrenaline, cortisol, elevated heart rate, elevated blood pressure. Over a full night, this means hundreds of sympathetic activation events. Over a year, that is tens of thousands. Over a decade of untreated severe sleep apnea, it is the equivalent of subjecting your cardiovascular system to hundreds of thousands of acute stress events while you are supposed to be resting and recovering. Sleep apnea affects an estimated 1 billion people worldwide. Approximately 80% of moderate to severe cases remain undiagnosed. It is the most prevalent sleep disorder in adults and one of the most prevalent conditions of any kind. And yet, in most healthcare systems, it remains dramatically underinvestigated, underdiagnosed, and undertreated, in part because its symptoms are so normalized. Snoring, daytime tiredness, waking unrefreshed, these are treated as minor inconveniences, as the inevitable consequences of a busy life or aging. They are not. They are the outward signs of a condition that is, in moderate to severe form, measurably shortening lives. In this video, I'm going to give you the complete clinical picture of sleep apnea. I will explain exactly what happens physiologically during an apnea event. I will walk you through the warning signs, many of which are not the ones people expect. I will explain the cardiovascular, metabolic, and neurological consequences that make untreated sleep apnea one of the most serious conditions in modern medicine. I will cover who is at risk, including the populations most consistently missed. I will explain how it is diagnosed and what the diagnostic process looks like. And I will give you the evidence-based treatments that work, including the most effective treatment in all of sleep medicine and the lifestyle changes that reduce severity measurably. Let us begin. To understand why sleep apnea causes such widespread systemic damage, you need to understand precisely what happens during each event. During normal sleep, the muscles of the upper airway, the tongue, soft palate, and pharyngeal walls, relax. In most people, this relaxation is partial, and the airway remains open. In people with obstructive sleep apnea, the relaxation is sufficient to cause partial or complete airway obstruction. The obstruction may be driven by anatomical factors: a narrow pharynx, enlarged tonsils, a retrognathic jaw, excess soft tissue from obesity, or by the inherent neuromuscular tone of the upper airway muscles, which varies between individuals. When the airway obstructs, respiratory effort continues. The chest and diaphragm still attempt to breathe, but no air moves. Blood oxygen saturation begins to fall. The peripheral chemoreceptors detect the falling oxygen and rising carbon dioxide and signal the brain. The brain generates an arousal, a partial awakening, sufficient to restore upper airway muscle tone and reopen the airway. The person takes several rapid breaths, oxygen returns to normal, and they drift back to sleep. The entire cycle takes 15 to 90 seconds. Then it begins again. There are two primary types. Obstructive sleep apnea, OSA, is by far the most common and is the focus of this video. It is caused by mechanical airway obstruction as described above. Central sleep apnea, CSA, is less common and is caused by a failure of the brain's respiratory control center to send signals to the breathing muscles. The airway is open, but the drive to breathe is temporarily absent. CSA is more commonly associated with heart failure, stroke, and opioid use. A third type, complex or mixed sleep apnea, involves elements of both. Most people with sleep apnea have obstructive disease, and the distinction matters because the treatment approaches differ. Sleep apnea severity is classified using the Apnea-Hypopnea Index, AHI, which measures the number of apnea and hypopnea events per hour of sleep. An AHI of 5 to 14 is mild, 15 to 29 is moderate, 30 or above is severe. However, the AHI alone does not fully capture the health impact of sleep apnea. Oxygen desaturation depth and duration, sleep fragmentation, and sympathetic activation frequency are also clinically important measures that a comprehensive sleep study will report. Most people associate sleep apnea with loud snoring and daytime sleepiness, and those are real signs. But the condition has a far broader symptom profile than public awareness reflects, and several of the most clinically significant signs are almost never connected to sleep apnea by the people experiencing them. Loud snoring is the most visible sign of sleep apnea, and the one most likely to be reported by a bed partner. The specific snoring pattern associated with OSA is characteristically loud, may involve snorting, gasping, or choking sounds as the airway reopens after an apnea, and may be punctuated by periods of silence, the apnea itself, followed by a sudden loud snore as breathing resumes. Not all snorers have sleep apnea, but all people with significant OSA snore. If a bed partner reports witnessed apneas, actually seeing you stop breathing during sleep, that is a strong clinical indication for urgent sleep study referral. The second sign, and the one I consider most diagnostically important for prompting investigation, is consistently waking unrefreshed. A person with untreated moderate to severe OSA may sleep 7 or 8 hours and wake feeling as though they have barely slept. The explanation is physiological. The repeated arousals, even though subcortical and not consciously remembered, prevent the normal progression through deep slow-wave sleep and REM sleep. These deeper sleep stages are essential for physical restoration, immune function, memory consolidation, and hormonal regulation. When they are repeatedly interrupted, the restorative function of sleep is profoundly impaired, regardless of total sleep duration. Excessive daytime sleepiness, EDS, is the consequence of the disrupted sleep architecture I just described. It ranges from mild, feeling drowsy in the afternoon, to severe, falling asleep while eating, in conversation, or while driving. The Epworth Sleepiness Scale is a validated 8-item questionnaire that quantifies EDS and is a standard part of sleep apnea screening. A score above 10 warrants formal investigation. Daytime sleepiness from OSA is one of the leading causes of road traffic accidents caused by driver fatigue, with multiple studies confirming that untreated OSA increases crash risk by 2 to 3 times. Morning headaches, typically a dull, diffuse headache present on waking that resolves within an hour, are caused by the overnight hypercapnia associated with apneas. Elevated carbon dioxide causes cerebral vasodilation, which produces the characteristic headache. Many people with OSA have been experiencing morning headaches for years and attribute them to dehydration, sleeping position, or stress. In the context of other signs on this list, persistent morning headaches should prompt a sleep apnea assessment. Nocturia, getting up to urinate 2 or more times per night, is a symptom that most people and most clinicians attribute to age, an overactive bladder, or prostate enlargement in men. In many cases, it is actually driven by sleep apnea. The mechanism is cardiac. Repeated apneas cause negative intrathoracic pressure that stretches the right atrium, triggering the release of atrial natriuretic peptide, a hormone that signals the kidneys to produce more urine. Treating OSA with CPAP therapy reduces nocturia in the majority of patients, sometimes dramatically. If you wake 2 or more times per night to urinate and have never been assessed for sleep apnea, this connection is worth investigating. Sleep apnea produces significant cognitive impairment through 2 mechanisms: the direct effect of intermittent hypoxia on neuronal function and the indirect effect of sleep fragmentation on memory consolidation and executive function. Studies of untreated moderate to severe OSA consistently show impairments in working memory, attention, processing speed, and executive function. Impairments comparable in some studies to those produced by moderate alcohol intoxication. Longitudinal data confirms that untreated OSA significantly accelerates cognitive decline and increases the risk of dementia, a connection I will cover in more detail in the consequences section. This is the sign that I think is most consistently missed in clinical practice. A person who has hypertension that does not respond adequately to antihypertensive medication, what clinicians call treatment-resistant hypertension, should be screened for sleep apnea in every case. OSA is the most common secondary cause of resistant hypertension. The repeated nocturnal sympathetic activation and the chronic elevation of cortisol and adrenaline produced by untreated sleep apnea drive blood pressure elevation that does not respond to medication because the underlying cause is not being addressed. Multiple trials have demonstrated that CPAP therapy in people with OSA and resistant hypertension produces significant blood pressure reductions, in some cases allowing dose reduction of antihypertensive medications. If you have been watching this series from the beginning, the consequences of untreated sleep apnea will feel deeply familiar, because they are the consequences of every condition we have discussed across 9 videos. Sleep apnea is not just a sleep disorder. It is a systemic metabolic and cardiovascular disease driver that touches every organ system we have covered. To your heart. Untreated moderate to severe OSA is associated with a 2 to 3 times higher risk of hypertension, a 2 to 4 times higher risk of atrial fibrillation, a 1.6 times higher risk of heart failure, and a significantly elevated risk of heart attack. The mechanisms are the repeated nocturnal blood pressure surges, the sympathetic activation, the oxidative stress, and the endothelial dysfunction produced by intermittent hypoxia. In video 5 on heart disease, I covered atrial fibrillation as one of the leading causes of ischemic stroke. OSA is one of the leading causes of atrial fibrillation. The chain of causation runs directly from untreated snoring to stroke. To your brain, the intermittent hypoxia of untreated OSA causes progressive neuronal damage in regions critical for memory and executive function, particularly the hippocampus and prefrontal cortex. Long-term studies have confirmed that untreated OSA is associated with a significantly elevated risk of both vascular dementia and Alzheimer's disease. The mechanisms include the direct toxic effect of hypoxia on neurons, the inflammatory cascade triggered by repeated arousal events, and the impairment of the glymphatic system, the brain's waste clearance mechanism, which operates primarily during deep sleep and is profoundly disrupted by OSA. To your metabolism. As I covered in video 4 on diabetes and video 8 on fatty liver disease, OSA drives insulin resistance through multiple pathways: sympathetic activation, cortisol elevation, sleep deprivation, intermittent hypoxia, and adipokine dysregulation from visceral fat. OSA is independently associated with a 2 to 3 times higher risk of developing type 2 diabetes and is a direct driver of NAFLD progression. These bidirectional relationships mean that obesity drives OSA, and OSA worsens the metabolic dysfunction that drives further weight gain, a self-reinforcing cycle that cannot be broken by addressing only one component. To your kidneys, OSA is an independent risk factor for chronic kidney disease progression through the combined effects of hypertension, intermittent hypoxia-induced oxidative stress on the renal vasculature, and the sympathetic activation that drives sodium retention and further blood pressure elevation. In video 3 on kidney disease, I described the vicious cycle between blood pressure and kidney function. OSA sits at the start of that cycle for a significant proportion of people with CKD. To your mental health, untreated OSA is strongly associated with depression and anxiety, not as a consequence of fatigue alone, but through the direct effect of sleep fragmentation and hypoxia on serotonin and dopamine regulation, and through the cognitive impairment that makes daily functioning harder and more frustrating. Multiple studies have demonstrated that treating OSA with CPAP improves depression scores significantly, in some cases to a degree comparable with antidepressant medication. Depression attributed to other causes that fails to respond to treatment should always prompt sleep apnea screening. The classic OSA risk profile is a middle-aged overweight man with a large neck circumference who snores loudly. And this profile is real. Obesity is the strongest modifiable risk factor for OSA, with each unit increase in BMI associated with a 14% increase in OSA risk. Male sex is associated with approximately twice the OSA prevalence of female sex, driven by differences in upper airway anatomy, fat distribution, and hormonal influences on airway muscle tone. Age is an independent risk factor. OSA prevalence increases significantly after 40 and continues to rise with each decade. But the normalized profile dramatically understates the prevalence of OSA in women, leading to systematic underdiagnosis. Women with OSA are significantly less likely to report the classic symptoms of loud snoring and witnessed apneas, which are the symptoms that trigger referral. Instead, they more commonly report insomnia, fatigue, morning headaches, and mood disturbance, symptoms that are frequently attributed to depression, anxiety, menopause, or thyroid disease without sleep apnea investigation. Postmenopausal women have OSA prevalence rates approaching those of men, driven by the loss of progesterone's protective effect on upper airway muscle tone. Any woman with unexplained fatigue, treatment-resistant depression, or uncontrolled hypertension should be screened for OSA. Lean individuals, those without obesity, represent approximately 20% of all OSA cases. In lean OSA, the driving factors are typically anatomical. Craniofacial structure including retrognathia and a narrow maxilla, nasal obstruction, enlarged tonsils, and inherent differences in upper airway neuromuscular tone. South Asian populations have a particularly high prevalence of OSA at lower BMI levels due to craniofacial anatomy and fat distribution patterns that predispose to upper airway collapse. If you are normal weight, non-snoring, or South Asian, and have unexplained daytime sleepiness or any of the signs I described, please do not assume you cannot have sleep apnea. Screening for sleep apnea begins with clinical assessment. The Stop-Bang questionnaire, 8 yes or no questions covering snoring, tiredness, observed apneas, blood pressure, BMI, age, neck circumference, and gender, is a validated high-sensitivity screening tool widely used in clinical practice. A score of 3 or above indicates intermediate to high risk and warrants formal sleep study referral. The Epworth Sleepiness Scale quantifies daytime sleepiness. Both tools can be completed in under 2 minutes and are freely available online. A home sleep apnea test, HSAT, is the first-line diagnostic investigation for most people with a high clinical suspicion of OSA. It uses a portable device worn overnight that measures airflow, respiratory effort, blood oxygen saturation, and heart rate. It calculates the AHI and provides a diagnosis of OSA in the majority of straightforward cases. HSATs are widely available through GP referral, sleep clinics, and increasingly through direct-to-consumer services. They are less comprehensive than polysomnography, but sufficient for diagnosis in most cases. Full polysomnography, an in-laboratory overnight sleep study, is reserved for cases where HSAT is inconclusive, where central or complex sleep apnea is suspected, where comorbid parasomnias or movement disorders complicate the picture, or where CPAP titration requires in-laboratory monitoring. Polysomnography monitors EEG, brainwaves, eye movements, chin and leg muscle activity, ECG, respiratory effort, airflow, and oxygen saturation simultaneously, providing a comprehensive characterization of sleep architecture and respiratory events. Here are the 8 interventions with the strongest evidence for treating sleep apnea and reducing its systemic consequences. These range from the gold standard treatment to the lifestyle changes that reduce severity significantly. Continuous positive airway pressure, CPAP, is the most effective treatment for moderate to severe obstructive sleep apnea and represents one of the most well-evidenced interventions in all of sleep medicine. A CPAP machine delivers a continuous stream of pressurized air through a mask worn during sleep, splinting the upper airway open and preventing collapse. A correctly prescribed and well-fitted CPAP device eliminates apneas in the vast majority of patients, reducing AHI from severe levels to below 5 events per hour. The cardiovascular benefits of CPAP are substantial. Reductions in blood pressure averaging 2 to 4 millimeters mercury and up to 10 millimeters mercury in people with resistant hypertension. Significant reductions in atrial fibrillation burden, improvements in left ventricular function, and reductions in inflammatory markers. Cognitive function, mood, and daytime alertness typically improve dramatically within the first 2 weeks of effective CPAP use. The primary challenge with CPAP is adherence. Approximately 30 to 50% of prescribed users use it for fewer than 4 hours per night. Adherence is the single biggest determinant of treatment benefit. If you have been prescribed CPAP and are struggling with it, there are masks, pressure settings, and adjuncts that can improve comfort significantly. Please work with your sleep clinic rather than abandoning the device. A mandibular advancement device, MAD, is a custom-fitted oral appliance worn during sleep that works by holding the lower jaw in a forward position, enlarging the upper airway and reducing its collapsibility. MADs are less effective than CPAP for severe OSA, but are a well-evidenced first-line treatment for mild to moderate disease and are significantly better tolerated than CPAP by many patients. Multiple trials have demonstrated that MADs reduce AHI, improve oxygen saturation, reduce blood pressure, and improve daytime function in mild to moderate OSA. They are prescribed by dentists with specialist training in sleep medicine and require fitting and follow-up to optimize effectiveness. Weight loss is the most impactful lifestyle intervention for OSA in overweight individuals. A 10% reduction in body weight produces approximately a 26% reduction in AHI, a clinically meaningful improvement that may move a person from moderate to mild severity or from severe to moderate. In people with mild OSA, significant weight loss may eliminate the condition entirely. The mechanism involves reduction of pharyngeal fat deposits that narrow the upper airway, improved respiratory muscle tone from reduced mechanical loading, and improved upper airway neuromuscular function. GLP-1 receptor agonists, which we discussed in the diabetes and fatty liver videos, are now showing significant OSA benefit in trials, driven primarily through substantial weight loss. The SURMOUNT-OSA trial of tirzepatide demonstrated a 62% reduction in AHI at 52 weeks in people with obesity-related OSA. Alcohol is one of the most significant and most commonly ignored aggravating factors for sleep apnea. Alcohol relaxes the pharyngeal muscles beyond their baseline tone, the exact mechanism that causes airway collapse in OSA, and suppresses the arousal response, meaning that apnea events are more likely to occur and less likely to trigger the arousal that reopens the airway. In people with borderline OSA, evening alcohol consumption can precipitate events that would not otherwise occur. In people with established OSA, alcohol substantially worsens severity. Benzodiazepines, Z-drugs, and opioids have similar effects on upper airway muscle tone and arousal threshold. Eliminating evening alcohol and reviewing sedative medications with a doctor are both high-yield interventions. In a significant proportion of people, estimated at between 30 and 50% of OSA cases, apnea severity is substantially worse in the supine position. When lying on the back, the tongue and soft palate fall posteriorly under gravity, further narrowing an already compromised airway. Positional OSA, where AHI is at least twice as high in the supine position as in lateral positions, responds well to positional therapy. Several devices are available that provide vibratory feedback when the person rolls onto their back during sleep, prompting a position change without full awakening. Positional therapy is particularly appropriate for mild to moderate positional OSA and can be an effective alternative or adjunct to CPAP in suitable patients. Nasal obstruction, from allergic rhinitis, nasal polyps, or septal deviation, worsens OSA by increasing upper airway resistance and promoting mouth breathing, which removes the stabilizing effect of nasal airflow on the upper airway. Treating nasal obstruction with intranasal corticosteroids, antihistamines, or where appropriate surgical correction can reduce OSA severity and, importantly, improve CPAP tolerability significantly in people who find nasal congestion makes CPAP uncomfortable. If you use CPAP and find nasal symptoms are affecting your ability to tolerate it, a nasal assessment is warranted before concluding that CPAP does not work for you. Surgical options for OSA include uvulopalato-pharyngoplasty, UPPP, tonsillectomy, nasal surgery, and in carefully selected cases, maxillomandibular advancement, MMA, which repositions the jaw to permanently enlarge the upper airway. Surgical outcomes for OSA are variable, and patient selection is critical. Tonsillectomy is highly effective in patients with tonsillar hypertrophy as the primary anatomical driver. MMA has the highest success rate of any OSA surgical procedure in appropriately selected patients. Hypoglossal nerve stimulation, an implanted device that stimulates the tongue muscles to prevent collapse during sleep, is a newer surgical option showing excellent results in selected patients who cannot tolerate CPAP. Surgical referral is appropriate for patients with clearly identifiable anatomical factors and who have failed or cannot tolerate non-surgical treatments. The most important action for anyone watching this video who recognizes the signs I have described in themselves or in someone they share a bed with is to complete the Stop Bang questionnaire and, if the score is 3 or above, to request a referral for a home sleep apnea test. You can find the Stop Bang questionnaire by searching online. It takes 2 minutes. The home sleep test takes 1 night, and the information it provides can fundamentally change the management of every other health condition you are dealing with. Blood pressure that does not respond to medication, fatigue that does not resolve with sleep, depression that does not respond to treatment, cognitive decline that seems to be accelerating. All of these may have sleep apnea as their driver. You will not know unless you test. 9 videos into this series, I hope the pattern is now unmistakable. The same conditions keep appearing as drivers of each other. High blood pressure, insulin resistance, obesity, sleep apnea, fatty liver, inflammation. They are not separate diseases. They are expressions of the same underlying metabolic dysfunction, each amplifying the others in a self-reinforcing system. Sleep apnea sits near the center of that system. Worsening blood pressure, worsening insulin resistance, worsening cardiac function, worsening cognitive health. entirely invisibly while you sleep. If you know someone who snores loudly, who wakes unrefreshed every day, whose blood pressure will not come down despite medication, or who has been treated for depression for years without resolution, please share this video. The information in it is not exotic. It is available, it is actionable, and it reaches people who can use it only if you pass it on. Subscribe so you do not miss video 10, the final video in this series, where I will bring everything together. The 10 conditions we have covered, the shared root causes, and the single unified protocol that addresses all of them simultaneously. The framework that makes prevention simple rather than overwhelming. I will see you there.